Hello everyone, I'm Dr. Park Charyam from Seoul Jongsong Dental Clinic. DentalBean played a truly crucial role in significantly improving my clinical skills, and it is a great honor for me to be lecturing here today. I always had this drive to put in my best effort and excel, striving to be better than everyone else. I wanted to achieve a skill level I'd be proud of, not compared to others, but for myself. However, for those of you who have graduated from dental school, or perhaps those who have completed residency training, simply obtaining your specialist license after graduation doesn't automatically guarantee excellence in your clinical skills, does it? I didn't have anyone specifically guiding me, so I pursued self-training and gained experience on my own. I'm going to share the insights and outcomes of that journey with all of you today, presented in a clear and accessible manner. My target audience for this lecture is dentists who are just starting out. Specifically, I'd like to focus on root canal treatment, or the endo field, rather than other areas. I'll be providing practical help for dentists who have just graduated, or those who have trained in specialties other than traditional classic fields, and therefore find themselves feeling quite overwhelmed by the root canal treatment commonly performed in the clinical field. Of course, I am well aware that there are many master dentists out there who are much more skilled than I am. However, I wonder if those master dentists have perhaps forgotten what it was like when they were just starting out. As they say, only a widow knows a widower's heart. I'm here to help beginner dentists overcome that overwhelming feeling. I believe I've probably attended almost all of the endo lectures and online courses available on YouTube or other platforms. On DentalBean, you'll discover numerous insightful lectures delivered by outstanding speakers specializing in the endo field. I specifically searched for DentalBean Endo and managed to capture one particularly striking lecture that truly caught my attention. A preview of Dr. Lee Dongbian's lecture is now available on YouTube, ready to be watched. What are your initial thoughts and impressions when you first see this thumbnail, particularly regarding the lecture? I felt like I had just stepped onto the ice for the very first time and was immediately expected to perform a triple jump. The moment I laid eyes on this radiograph, this fitting image, it immediately felt as if our novice dentists, much like someone trying to skate for the very first time, were clumsily crawling along. We're being told, hey, do a triple jump. Of course, he is a wonderful and highly skilled teacher, but it might be a bit challenging for novice dentists to follow along. I mentioned that I trained myself, didn't I? Who molded me into the dentist I am today? I thought it was Seoul National University or Seoul National University Dental Hospital, but I don't think so. While school gave me a solid foundation of theoretical knowledge, it didn't really offer extensive opportunities to truly refine the practical skills and clinical techniques essential for seeing actual patients and performing treatment in a real clinical setting. The two platforms that were truly instrumental in shaping me into the dentist I am today were DentalBean and YouTube. I listened to many lectures by Dr. Cho Young-sok and Dr. John In-sung on DentalBean. YouTube is also overflowing with videos that have been made by countless master surgeons and expert practitioners. I didn't enter dental school, but the graduate dental program, the dental professional school system. I doubt I'd have gotten into Seoul National University without online lectures. It's the same when it comes to improving a dentist's clinical skill. I honestly believe that without these online lectures, without DentalBean or YouTube, my clinical proficiency would not have reached its present level today. The benefit of these open online platforms, I believe, is the way knowledge isn't concealed, but rather is freely shared with everyone. It seems that the era of hoarding knowledge and only gradually imparting it to obedient disciples, teaching in a supplementary manner, is now over. Ultimately, I believe we are now in an era where each individual must diligently seek to enhance their own abilities, constantly researching and putting in the effort to improve their skill. And as a result, this is precisely what I have become. In fact, it's quite rare for a general practitioner to perform dental treatment while using a microscope. To achieve this level, what kind of clinical practice have I been carrying out? And if I'm not capable, you wouldn't want to learn from me, would you, fellow dentists? Nevertheless, I want to show you that I have the skill to teach other dentists. This is a radiograph of mandibular number 7 after key-shaped endo access. When it comes to mandibular molars, you might often assume they commonly possess 4 canals, but in actual clinical practice, it's far from being that straightforward. In between these root canals, more concealed spaces are often present within the isthmus connecting them. I took this picture to assess the situation fully and then to show the patient the crack. You can clearly see the crack line right here. This is also a photo I took to show the patient the crack. Cracked endo. This broken tooth. This one. Shall we look at before and after? Before. This broken tooth, along with an endo crown and core, was utilized. On the radiograph, I don't see any major issues. This patient, who follows up diligently, is actually my mother. She came to our clinic for her first visit, and wow, her face was quite swollen. Let's examine the intraoral and clinical images now. If you observe carefully, you can clearly notice a significant cavity and some gum swelling in this area around tooth number 20, isn't that right? I believe this is a case where the infection wasn't confined to the tooth but spread to the fascial space of the face. I didn't perform any special treatment. I only performed I and D for the gum swelling. After an endocrown on tooth number 24, which seemed to be the causative tooth, the patient's symptoms disappeared. This is a commonly seen cracked tooth. On the radiograph, I had a really hard time taking this picture. Here, if you observe closely, do you notice the crack that has extended all the way to the pulpal floor? Since it extends all the way to the pulpal floor, this particular one, I angled it slightly to capture the MB2 orifice. Usually, in cases like this, you'd perform an extraction, right? I suggested extraction, but the patient had no pain and wanted to use it as long as possible, even with a short lifespan. So I agreed. Then we did the endocrown. After removing the crown, here is the pre-op panoramic X-ray. Post-op pano. I think there's been some bone healing. Since I haven't heard from them, it seems they're using it well. In mandibular molar root canal treatment, this here is our mesial canal. In the mesial canal, you usually assume there are two canals, the MB and the ML. But how many gutta-percha cones are actually inserted? 4 are inserted. 4. Oh. The root canal system is not as simple as we might believe, up to the point where the gutta-percha cone is inserted. This is an X-ray image taken after the filling was completed, having successfully secured and thoroughly cleaned the isthmus space. Number 17, distal caries. Access is tough. Distal caries number 17. Treated difficult distal caries number 17 and completed with an endo crown. These are pre-op and post-op periapical X-ray images. For those of you who are dentists and have an interest in the endo field, you might already be familiar with this. But when you examine the X-ray, after correctly aligning the distal side and adequately removing the cavity, you'll observe that the white line here stops partway, doesn't it? This is a patient case where we performed what's commonly called MTA pulpotomy these days. In formal terms, it's vital pulp therapy. If we look at one more case of vital pulp therapy, or VPT, this patient experienced ambiguous symptoms. They felt discomfort, food got stuck, and pain made chewing impossible. The cavity hadn't progressed far into the canal, and I had confirmed the vitality of tooth number 27. After performing vital pulp therapy, I captured this image of the tooth filled with MTA material. Many patients come to our clinic with incredibly large cavities like this. The cavity on tooth number 27 is incredibly large, but let's zoom in a bit more. In this particular patient's case, only a slight portion of their pulp was in an inflammatory state. I carefully assessed the vitality of the canal orifice, and then, after confirming its health, I concluded the treatment with a vital pulp therapy. I will now proceed to present more patient cases to you. This is tooth number 12. If you examine tooth number 12 closely, it appears to have been a post and crown, but the crown had a fracture. This is a periapical X-ray showing the crown fracture. Looking at the patient's intraoral photograph, there is no ferrule effect. I may have to make an extraction diagnosis. Let's take a look at the frontal view. Yes, there's no ferrule. Extraction may be necessary. However, the patient was young, a male in his 30s. Yes, I removed the post and retreated. I'm currently applying concentrated force only on this particular tooth for a post-eruption to create a ferrule, and I'm in the process of pulling it. The cases I've shared showed how I used endocrowns to save natural teeth, alleviate symptoms, and preserve teeth. As a GP, I handle diverse cases, including resin fillings that you're all familiar with. I also perform inlays when I have time. Lately, I've been taking impressions with an intraoral scanner. This is an X-ray image taken to ensure the margins are well aligned and there's no residual adhesive material left. For this particular patient, I had initially intended to perform a treatment on tooth number 16. Can you observe this distinct dark shadow that is clearly visible and shining through from underneath the gold inlay? Even if it's not clearly visible on an X-ray, by taking a DSLR camera photo with sufficient flash, the inside of the tooth will be illuminated, allowing you to diagnose a cavity that you wouldn't be able to detect with your eyes or a typical X-ray. This is a panoramic X-ray, not a periapical X-ray. Let's take a look at the periapical X-ray. It has a specific characteristic. Alright, this patient has a really huge amount of subgingival calculus right here. It seems like the area under the gold inlay was never cleaned. We removed the existing restoration from this tooth and performed a full crown vital pulp therapy. We also thoroughly removed the subgingival calculus. This scan shows the actual clinical field. If you observe very carefully, can you notice that somewhat sunken space between tooth number 16 and tooth number 17? This was a case where, even with poor periodontal conditions, we thoroughly cleaned the crown preparation and the internal area to ensure healthy gums before seating the crown. Naturally, we'll also perform an implant procedure. Today, a patient's tooth fractured, and they informed us their wedding was just a week away. We absolutely had to find a way to resolve this for them. I tried my best to save it, but if you look closely, the inside is contaminated with a dark color. So instead of uncertain treatment due to the patient's major event in a week, we did immediate implant placement post-extraction. Naturally, we planned with CT, and since the patient was young, there was ample bone. Still, to place it in a limited bone space, I don't use large diameter fixtures. A 4.0 diameter fixture, placed in its originally planned position, including the temporary crown both before and after this, is the extent of my proficiency. For your reference. Yes, for that fixture, an Ostem TS3 non-hex fixture was used. This reduces the fixture's diameter. Also, due to my clinic's location, many patients with very poor health conditions seek my care. I can resolve cases of fascial space abscesses like these. And there are also patients who develop canine space abscesses. I also provide treatment for these kinds of patients. What I want to share in my introduction is that I believe many of our dentists tend to consider endodontics vaguely difficult. Many are recent graduates, or just finished their specialty training. They specialized in prosthodontics, but are told to do endo. What should they study? What books should I read? I think many of you are probably wondering what to study, but my opinion is this. Dental practice is not mathematics and science. Of course, we must practice evidence-based treatment, reviewing paper data, and relying on scientific evidence. However, our field doesn't require the same rigor as mathematicians, nor can it ever truly achieve that level of exactness. Academic papers and articles in the field of dentistry cannot even begin to approach the logical completeness and rigorousness of mathematical proof systems. Before I came to dental school, I graduated from the chemistry education department at the College of Education. And even if I compare dentistry to chemistry or even natural science, I don't think it can compare to the rigor of science itself. So if dental practice isn't mathematics or science, then what exactly is it closer to? I think it's like exercise or performing music. We're about practical application, not just studying. Ultimately, we must show results through performance. Arnold Schwarzenegger is my favorite bodybuilder. Did you know that there's a particular exercise he popularized and that became widely known? When doing shoulder exercise, people usually say to lift like this or do shoulder press like this. But there's a workout method Arnold popularized, the Arnold press. They say it makes your shoulders grow better. He just slightly changed the movement. But is there a randomized clinical trial paper proving the Arnold press is truly effective in the realm of bodybuilding? I'd venture to say probably not. Would you agree? Didn't everyone just follow along because Arnold tried it and said it was good? Music works similarly. We have our standard musical scores, but let's consider classical music performance as an example here. Even though performers might have the exact same musical score, their individual approaches to playing it differ, don't they? But the fundamental rule is that you put your own interpretation into the musical score, right? I believe our clinical practice is quite similar to that as well. You simply need to meticulously adhere to the basic principles and achieve the outcomes you desire, each in your own distinctive way. To perform music well, study is certainly needed, like knowledge of harmony. However, I don't believe a lack of knowledge means you are unable to perform music. For example, the world-renowned master singer Luciano Pavarotti reportedly couldn't read musical scores. Even if you can't read sheet music, you can still sing world-moving songs. So I have some rather bold advice for those of you who are just beginning as dentists. My recommendation is, don't focus too much on research papers. You don't have to make it too difficult. In the end, I strongly advise you to choose to primarily follow the methods of the highly experienced practitioners and master dentists who have steadily pursued the existing clinical path. He's a professor I profoundly respect from my university, and watching his surgeries, I was truly astonished. I also vaguely remember this. Our typical silk suture size that most dentists commonly use is 4/0 or 5/0. However, I once witnessed a surgery where he was suturing minute blood vessels, virtually imperceptible to the naked eye, using 10/0 sutures under a microscope. I was truly amazed and thought, wow, that's absolutely incredible. But I know that Professor Lee Jong-oh sees many patients with nerve damage and sensory impairment, so there must be a prescription that Professor Lee Jong-oh gives. Is there paper evidence Professor Lee Jong-oh's prescription is superior to other nerve damage prescriptions? You'd have to experiment on humans, and I believe it would be difficult to get accurate evidence. Ultimately, we have no choice but to follow the masters. Clinical practice is not mathematics and science. So, I'm going to explain to all of you, my fellow dentists, what I advocate for, and how I can help elevate your skills to this very level. Now, have you ever seen this graph before? The horizontal axis is my skill, and the vertical axis is my confidence. In the beginning, you don't know anything, so you lack confidence. But once you start to learn a little, you think, wow, I'm doing really well. Your confidence skyrockets. Yet, as you gain more knowledge, you realize the immense scope of this world, leading to frustration. You sink into a swamp of despair, convinced you know nothing. However, as you steadily build your skills, you ascend the hill of enlightenment, reaching a point where you sense, now I think I'm beginning to grasp it. They say you reach that summit. I believe I am currently at about this stage or somewhere near it. Master teachers with 20 or 30 years of clinical experience would have already passed this hill of enlightenment and reached that summit. However, these esteemed teachers certainly don't recall their tadpole days. It's a distant memory for them. I believe I am currently at this particular stage. I feel like I'm someone who's just escaped the valley of despair. To all you dentists out there, when you are thrust into the clinical field and told to perform root canal treatment immediately, instead of feeling overwhelmed, fearful, and finding it challenging, I believe that by taking my class, you will be able to steadily follow along and acquire the expertise necessary to diligently treat each and every patient. You can simply follow along like this. Don't worry about it. Just follow. Why do I say this with such an assertion? Before I started this class, I actually went and got advice from a master teacher who is much more skilled than I am. What that great master teacher told me was that I should not seek out or try to come up with the correct answer. There's no correct answer in the world or clinical practice. We don't know much. I genuinely believe that's absolutely correct. However, that particular stage doesn't really hold much significance for dentists who are just starting out. For someone who knows nothing yet, saying it could be this way or that way, or the correct answer could be this or that. It's too confusing, right? My favorite great person is Sigmund Freud. Sigmund Freud explained human psychology and social phenomena with just one keyword, didn't he? He explained it with the keyword sex. Of course, this explanation method was wrong. How many explanation methods in the world could there be besides sex? However, the reason I truly admire Sigmund Freud is that almost anyone can explain how things could go in various directions, and how numerous elements contribute to any given outcome. And among all those many components, I aim to pinpoint one crucial element and convey it in a single phrase to dentists just embarking on their professional journey as a comprehensive lecture. My explanation will be a single word, much like Sigmund Freud's. I'm going to be brief, and naturally, what I say will be incorrect. However, I truly believe that my seemingly incorrect words will be exactly what new dentists need as they embark on their journey. Thank you for listening so attentively.